Well, good afternoon, almost good evening. Welcome to the Biotech Satellite Symposium, Accessing Patient Satisfaction with Biotech Advanced Technology IOLs. As a chair of the event today, it gives me a great pleasure to welcome you all. Myself, my name is José Güell. I'm founding partner and doctor specializing in corneal and refractive surgery at IMO in Barcelona. I have been the president of the IMO Foundation for a while and professor of the master course in the anterior segment and master course on corneal and refractive surgery at the same institution. And also I teach at the ESASO in Lugano. Today we will share our experiences about biotech premium IOLs with you. And I would like to introduce these very well-known speakers that we have here. Dr. Detlef Breyer from Germany, Dr. Ramon Ruiz Mesa from Spain, Dr. Alper Atka from Turkey, Dr. Florian Kretz from Germany, and Dr. Alexandra Arango from Spain. We also have with us Dr. Ertan Sunay from Turkey as expert specialist for this session. He is the medical director of the Benibidi Group of hospitals in Turkey, and is associated with many national and international societies like the Turkey Ophthalmological Society, the Pan American Association of Ophthalmology, American Society of Cataract and Refractive Surgery, the European Society of Cataract and Refractive Surgery, and the European Society of Retinal Specialists. Well, no more delay. To start with today's session, I would like to invite Dr. Detlef Breyer. He is founder of the International Vision Correction Research University Eye Clinic in Heidelberg, Germany. He also co-owns the Breyer Einkaimak and Club and Premium Eyes Eye Clinic in Düsseldorf. Today, he will share his first results with this Eyecryl Phakic toric IOLs.
So, thank you very much, Jose, for a nice introduction. So after I've been implanting the ICL for 18 years, there came this new kit on the block. And of course, I was interested. This is an Eyecryl Phakic toric IOL. It's a hydrophilic acrylic IOL with an ultraviolet filter. You can get it for hyperopia and myopia. The incision size is 2.8 millimeters, or dock-on technique with 2.2 millimeters is possible too. You have those orientation marks, as you can see here, on the correct side of the lens. You can implant it when you have a wide-to-wide range from 10.5 to 12.6 millimeters. And they are available in stock. What is new, also for hyperopia, and what I do like very much for hyperopia with a central hole, because especially in those eyes, you have to have this safety measure to have a central hole, not to get an angle closure glaucoma. The holes in the periphery are 0.5 millimeter, and in the center 0.6, not to get haloing glare or photopic phenomena. So this is the diopter range from +10 to -25 in 0.5 diopter steps, and you have 4 overall sizes, as you can see here. This is spherical range and the cylindrical power range. This is the Eyecryl Phakic toric IOL. So I want to talk only about my first 10 implantations. Of course, those patients, as they've been the first ones, they got informed that this is a new ICL. Those were the parameters I was checking. And if you have a look at the first 10 predictability sphere, this is made me more than happy. Same with the cylinder. Perhaps quickly, I have to explain how I orientate the IOL. I do simultaneous iridography and LED keratography. Those data go into the Schwind laser. The Schwind laser does measure the cyclar rotation and does a mark with trans-PRK on the cornea. So I think the whole system works so perfectly, plus obviously excellent lens, that you have no residual astigmatism in the patients. Taking this together, of course, the spherical equivalent is great too. The rotational stability is within what we know from other ICLs or IPCLs, and also an excellent value. We measured this with a barometer. This is an uncorrected distance visual acuity, better than 2020, so happy with those results as well. And the endothelial cell count is also very comparable to the data we know. The IOP, okay, we can see it went down a little bit, but I think this is in the normal measurement failures, so basically I think it is the same. Here you can see a video of the implantation. That's how you take the Eyecryl out of the holder, implant it into the cartridge, and as you can see, you implant it like an IOL, close it, put the cartridge into the injector, and then I inject the Eyecryl into the eye with a dock-on technique through 2.2 millimeter with cohesive, filled with cohesive viscoelastic. You can see here, this is, I'm implanting now with the left hand, sitting as at the 12 o'clock position. And what I do like about this IOL implantation technique, that it's a little bit stiffer than the ICL and very much stiffer than IPCL. So it's easier to implant. It makes life easier and unfolds easily. The only thing you have to remember if you're used to an ICL, it unfolds and enters the eye V-shaped. So take care not to touch the crystalline lens. You can here see it's a toric one. And at the 12 o'clock position, you might see when I move the eye, the trans PRK mark. And you have this at 12 and 6 o'clock position, the trans PRK mark, and Eyecryl is realigned. Good. So what is also perhaps for the one or the other person interesting is if you implant it into the cartridge, it's like an IPCL. That means it's not like an ICL. You don't have to pull it forward. Nicely in a way, as those of you who implant ICLs know, this grasping forceps, on the one hand side, it's very expensive. On the other hand side, the sterilization process is often done by people who are not microsurgeons, and they can get destroyed very easily. So this is really a money-saving procedure. So what I said before, in contrast to the ICL, the Eyecryl leaves the cartridge U or V-shaped, like an IPCL. So be careful not to touch the crystalline lens. If you're used to implant an ICL, the placement of the haptics and rotation especially is very easy because it's the most rigid of the ICLs we know. IPCL is very floppy and it has the big holes in the haptics, so it's the one who's most complicated to implant. The ICL, we're used to it, and the Eyecryl, I think, is especially also nice for those people who start with implantable contact lenses. So the results, at least from the first patients, are very good to excellent. It's an Eyecryl that is easy to implant. You don't have to pull forward. That saves money and nerves. It's most rigid of all phakic IOLs. If this is an advantage or disadvantage, we don't know yet. We don't have long-term results, so that's why we inform our patients that this is a new product when we implant it. And I'm happy they're on the market because what we could see over the years, that competition really stimulates the business. And so I'm also hoping for an EDOF IOL because those patients often are around 40. And of course, it's good if you have an EDOF IOL and can say we can make a blended vision, and this is for lifelong until you may need a cataract surgery. So you will not depend on readers when you get 45 or 50. Thank you very much for your kind attention.
Thanks very much, Detlef. I think that because the topics are slightly different between one speaker and the other, we will open a turn of questions. So, any questions for Dr. Detlef from the audience or from the panel?
Well,
Ertan?
I would like to. Sorry. I would like to have a question to Dr. Breer. Does the all diopter range has a whole or only the myopic lens? Do we need to perform iridectomy or iridotomy while implanting hyperopic models?
No, we don't have to. As I mentioned at the beginning, I think this is a real advantage if you implant hyperopic IOLs. In 18 years, I never had big problems, but at one case last time, where I really had to explant a hyperopic ICL because the patient had a plateau iris syndrome, and I haven't seen it. And the first day, 20/20 vision, second day, happy patient, he was +7, and third day he came with really pain in the eye, and he had glaucoma. So I had to explant it. And you can imagine if there's a high pressure and you have to explant the ICL and the pupil gets small, it's not a nice surgery. So I think even if you have a plateau iris syndrome, it would have been great to have aqueous flow through the ICL, through the lens.
Okay, thank you.
But if you have a plateau syndrome, basically was a close glaucoma, a close angle.
Yeah, yeah.
So I don't think.
But the question is what leads to it.
Yeah, yeah. Because
I feel a little bit more comfortable with an aqueous flow.
No, but I'm saying that because possibly, in this case, if the pre-op has this kind of risk factor, I don't think it will make any difference having a hole or not. But okay. And regarding the holes, don't you think that in the vast majority of cases, possibly with the peripheral ones, would have been enough?
To have peripheral holes? Yes. Usually they are enough. I had one case of a woman getting pregnant, and it was a friend of mine, and so I knew it was perfect. I did it by myself. It was a friend of mine, so I had this patient very good in mind. And she got pregnant, and due to the swelling of the tissue and crystalline lens, the iridotomy closed.
Okay.
Yeah. I never experienced this before. Those are two crazy situations where I thought maybe a central hole would help.
Yeah. Okay. No questions? Well, thanks very much, Dr. Bradley. So I now would like to introduce and invite Ramon Ruiz Mesa. He is Medical Director for Andalucía at the Optiflex Group. He belongs also to the Board of Directors of the Spanish Society of Refractive Implant Surgery, possibly you know the SECOIR, and the Spanish Society of Ophthalmology, the SEO. He is also associated with the ESCRS, ESCRS, ISRS. He's associated with almost everything. He is a very well-known speaker and surgeon. And today he will talk about the Eyecryl Phakic toric IOLs, his initial results in comparison with other phakic IOLs.
Okay, thank you so much to Biotech team for the kind invitation, of course, for your kind words, Dr. Well. Effectively, I am going to talk about our initial, I have the short experience, clinical result and a comparison with other phakic IOLs. You are going to underline the main feature if we compare these lenses with other lenses from the care group or Star Surgical. We underline the ultra-high purity of this type of lenses, Biotech lenses, with less than 0.02% of impurities. The longevity of the material is a very important thing. 40 years warranty on the base material with the least acrylical material that I am going to explain the other slides. Very good thing, as my friend Detlef has explained to us before, It's very easy to implant this type of lens. And one of the main advantages in order to maintain our SIEA is the incision size. We can introduce this lens through 2.8 millimeter versus 3.2 of other Phakic lenses. The trophilic material, okay, it's the same that another company, but without porcine covering. Regarding this lens material manufacturing, we have to underline the methacrylate acid material, ionicity 0, with a polishing precision less than 1 micron error. About the loading and injection, it's very easy to manage this type of lens. We can show the video of Dr. Debler before. No difficulty, and the great advantage for me is the injection in U way, treating to don't touching the lens when we are implanting, repeating through 2.8 millimeter. Regarding the better optical zone, I think that we have to underline the Phakic pupil coverage. We can see always in this type of lens around 7 millimeter, but even it's a great difference when we are talking about high diopters of myopic patient. At the same time, we maintain this type of lens, the spherical design, in all orders the lenses and all orders the diopters. Of course, if we talk about diaperopic lenses, we can result that in this type of lenses, we don't need to give laser previously on surgery or an anerectomy intrasurgical time because they maintain the same hole in the center like myopic lenses. This is a brief summary about my first experience after 2 months of follow-up. 16 eyes, 8 patients, 12 spherical IOLs and 4 torics with an age on the average of 28 years old. The bulk, the average was 550 after 1 month of the measurement. If we talk about the safety and efficacy, we found very good values, 1.24 and 1.36. The interstitial cell count not changed after 1 month after the surgery. Regarding IOP, usually the first week we can maintain a little bit bigger the value of IOP, maybe for steroids topical drops, and after 1 month we maintain the same, even less IOP. If we talk refractive results, the spherical equivalent, after the first week in log-Mager scale, we obtained 0.03, and after 1 month, 0.08. If we distinguish between spherical and astigmatism, after 1 week in log-Mager scale, we obtained 0.25 and 0.21, very good result. Astigmatism, absolutely very good result if we are talking about the diopter, but without rotation in any case. I think that I know that is a short zone. And if we talk about the uncorrected distant visual acuity in decimal scale, we found 1.24 after 1 month. At the same day of the surgery, we can find very good visual acuity for the patient. And even the best corrected distant visual acuity, we can increase until 1.36 after 1 month of follow-up. In summary, I think that the purity and performance of the material provide better safety and surgical handling for the surgeon. Sizes, we can have lenses size with a size from 12 millimeter to 13.5 in 0.5 millimeter steps, and especially size 13 millimeter, providing very good ball control. And of course, I think that the safety, efficacy, and refractive result are excellent for the patient and for us. Thank you so much for your attention.
Thanks very much, Ramon. Again, questions? Well, you're open. I will not ask. You're open to make questions whenever you wish. There are microphones with numbers. Yeah.
So, Ramon, I would be interested, because you're a high-volume surgeon for a very long time. You have many experience with other ICLs, IOLs. What is your gut feeling about the rigidity? Do you think this is on a long-term basis an advantage or a disadvantage?
Well, I have a lot of experience, effectively, with ICL from the start. I think it's a very good lens, of course. My first feeling, because now I can speak only about the impression, the short experience. But with this type of lens, for me and for my assistant, it's easier to manage the lens in order to unfold and to implant. It's a little bit rigid. In my case, I like it. And the material, I suppose, acrylic hydrophobic material, we can think about a long time in a safe way for maintaining in the eye and at the same time maintaining the refractive result.
Ramon, no doubt that having more steps in the mean length of the lens regarding the control of bolt is an advantage. But the way that you measure it is exactly the same for this lens that for any other, no? So, but at least you would have the possibility to exchange the lens if necessary with a much more precise way, no?
No, I think that it's the same because well, we can check in artificial eyes, but for the material and my experience with another intraocular lenses for pseudophakic patient with the same material, we can't do wider the main incision.
Okay. Any question?
Well, what about the hole in the center, Dr. Mesa? Does it create any visual disturbances in the patients, the hole in the optics in the center of the IOL?
Yes, at the beginning when I began with the practice of ICL with the whole central, it was the first question that all the surgeon we ask for the company. It's true that I can't receive any claim from the patient, and we have a different measurement, contrast sensitivity, looking for photophenomena, even in sclerotopic condition, and I don't have any experience in this way. In this case, with the new Eyecryl from Biotech, I think that it will be the same result.
Okay, thank you. Thanks a lot.
Yes, this is a topic. Thank you, Ramon. And this is a topic because there are not too many people, but there are some that appears from time to time. And so at least I think that we all need to advise them that this is a very rare possibility, but that this exists because from time to time one patient comes to you with this with this problem. So, okay. My pleasure is to invite Professor Albert Akka. He will be virtually with us. He is an associate professor in World Eye Hospital in Istanbul. He is Cataract and Refractive Surgery Unit Board member of the Turkish Ophthalmological Society and has been user of the Eyecryl Phakic IOL for the last 5 years. So he possibly is one of the, if not the one, with the longest experience with. So he will talk about his long experience with it.
Dear moderator and dear colleagues, I will present my long-term results with Eyecryl Phakic intraocular lenses. I will also talk about potential complications of phakic intraocular lenses.
Okay.
This is a case series of 5-year follow-up.
Okay.
36 eyes were included. Main outcome measures were visual acuity, spherical equivalent of manifest refraction, and endothelial cell density. Complications were also recorded. Mean spherical equivalent of the patients was -13 dioptries, and minimum anterior chamber depth was 3.28 millimeters from the endothelium. Mean anterior chamber depth was approximately 3.5 millimeters. 80% of our patients were above -10 dioptries, and approximately 25% was above -15 dioptries. The spherical equivalent in the study is relatively high when compared to other studies in the literature, because we usually prefer phakic intraocular lenses in very high myopia. Up to 8 to 10 dioptries, we usually prefer corneal refractive surgery. At the end of the follow-up, at the end of 5 years, there was a statistically and clinically significant regression. And this was an expected finding because 25% of our patients had 15 dioptries or more myopia. This is a very high level of myopia. And myopia is usually progressive in this patient group due to axial length elongation. As a result, after 5 years, only 50% of the patients were within 1 dioptries of the attempted correction. And only 36% of them was within 0.5 dioptries. However, efficacy index was still 1.2. That means mean postoperative uncorrected visual acuity is higher than mean preoperative corrected visual acuity despite residual refractive errors. That's because most of the patients experienced an increase in corrected distance visual acuity. In this study, 67% of our patients experienced 1 or more lines of improved visual acuity. Endothelial cell loss from preoperative visit to 5-year visit was approximately 4%, and endothelial cell density loss after 1 year was not statistically significant. Take-home message for us is in high myopia, I mean more than 10 dioptries, 50% of the patients will be more than 1 dioptries myopic 5 years later. So in terms of early patient satisfaction, you might choose slight myopia, but you should keep in mind that there will be a refractive shift during long term, and emmetropia or slight hyperopia is not a problem. And it may be more desirable if you aim long-term refractive stability, but if you aim for short-term patient satisfaction, near vision is more important, and you may choose for slight myopia. We say that the Eyecryl Phakic intraocular lens was safe for the crystalline lens and endothelium in our study, in our patient group, and we saw no significant complications. Now I will talk about potential complications. These are not about these 36 patients. These are general potential complications. First, you may have haptic entrapment during the surgery. This is very rare, and still the solution is very simple. You can cut the injector with a cautery, and the problem is easily solved. This case was sent to us from another clinic. I'll show this because I want to show that zonular dialysis is possible if you make the surgery very traumatic. In this patient, the lens was explanted. Pupillary block glaucoma is extremely rare due to the central lobe. I've seen it only once among more than 600 cases. But because I saw it in one patient, I don't use a myotic agent, and I still discharge patients only after 2 or 3 hours later after the surgery, and I check for the intraocular pressure and pupillary block. Uveitis is a rare complication of posterior chamber phakic intraocular lenses, and it will always fully resolve after steroid treatment. This is a case of uveitis after another posterior chamber phakic intraocular lens, but you may see it with Eyecryl also, but you should be sure that it will resolve with topical steroids. Refraction may be a complication, may be regarded as a complication. As I said before, you should choose between early patient satisfaction or long-term emmetropia. If you aim early patient satisfaction, a slight myopia is better. If you aim better refraction at long term, emmetropia is better. But in this case, you must talk with the patient that he or she may have near vision problems. Otherwise, you may have problems with the patient. Cataract is very rare also. It's certainly less than 1%. And for intraocular lens calculation, axial length measurement error is approximately 0.1 millimeter. And this is not a clinically significant error. So you do not have to make intraocular lens calculation variations. The biggest problem with posterior chamber phakic intraocular lenses has always been the size. A low volt is not an acute problem if the lens is stable. However, a high volt may cause acute problems like refractive shift, halo, glare, inflammation, and discomfort. So if the volt is low, I usually don't change the lens unless it's unstable. But if the volt is high and the patient feels uncomfortable or anterior chamber is shallow, I change it. This is how I explant the lens. I give the lens this position before removing it from the anterior chamber, but I will show it with a video. You put the lens in the anterior chamber and simply remove it. It's very easy surgery, and you can replace it with a new intraocular lens. In conclusion, I will advise you to check twice before choosing the smallest or the largest size to avoid complications. Replacement may be necessary if the lens volt is too high or too low. You should choose between early patient satisfaction, that means better near vision, versus long-term refraction. And I want to underline that cataract is extremely rare and other complications are rare and easily manageable. Thank you for your attention.
Thanks very much, Alper, for to share with us your long-term experience. Could you hear us? No.
Connection issues.
Okay. Okay. Well, I had one question. Perhaps some of you could clarify it to me. It looks like, or at least I understood, perhaps I am wrong, that to prevent pupillary block, he does not like to use neither myocol or pilocarpine at the end of surgery. And but so it looks like that for him, and I would like if for you too, the pupillary block is mostly an early post-operative problem. That's what you think. Yeah. Okay. Okay. Here is back again.
Came again, right?
I have a short problem with internet connection, so I could not hear the question. Can you please?
Hi, Alper. Thanks very much. This is Jose from Barcelona. The question was that you talk about the recommendation of not to use myocol or acetylcholine at the end of surgery. This will not work. Okay. Let's leave some time if he can solve the connection.
Can I just raise a question for discussion?
Yes, of course.
As Alper showed that there is a progressing myopia in those patients, but the early outcome is better with patients that he targets slightly myopic. Would it be an option to maybe resync the procedure and target on a slight monovision with a distance target of plus 0.5 in one eye and emmetropia in the fellow eye? So basically when the patient starts to truly become presbyopic, he still has one eye that is emmetropic by then, or maybe only slightly myopic, and the other eye he has a little bit of monovision, but he also has the time to get used to it by the time that he has the lenses implanted?
Well, I am not using posterior chamber phakic IOLs, but conceptually speaking, I agree with you. Although this is a decision that obviously will will be related with the age of the patient. So if you're going to do this surgery in a 25 years old individual, I don't think that you need to take care of that, because at least in my experience, despite that you are neutralizing both eyes, they have some, let's say, initial discomfort for near vision. After a couple of weeks, they are perfectly well. This is much more trouble when you're doing surgery on the 30 lates or the early 40s. In those cases, yes, I would personally agree with your suggestion, independently of the phakic IOL you're going to use.
And I think I also like the approach, and I do the same as Florian does. The only question is interpreting the data. Did you ever have a look at those getting more myopic in a shorter time if they have been stable 2 years before surgery?
Can you hear me?
Yes, we can. Yeah, we can hear you.
Yes. We did not make a subgroup analysis for the patients who are less myopic, but we expect regression in all patients due to axial length elongation. And my experience is that nearly all patients after phakic intraocular lens implantation who have moderate or high myopia will experience near vision problems. Either you should explain them that in short term they may experience with near problems, or in long term better refractive. You should choose between them. There is no ideal solution, because in moderate or high myopia there will be increase in myopia in long term. And it's due to axial length elongation. So there is no solution for that. The only solution may be corneal refractive surgery when there is too much regression.
Okay, thanks very much, Albert.
LASIK.
We need, I think that we need to move on. Thanks very much, and we are sorry because of the problems of connection. And now I have the pleasure to...
I apologize for the internet connection.
So I have the pleasure to invite Florian Kretz from Germany. He's the founder and CEO of PVK Precise Vision. He has established 2 new treatment methods for cataract surgery at the Precise Vision Ophthalmology Centers, published more than 100 scientific articles in the specialized ophthalmological press, and he will share his first results with the Optiflex TRIO.
Thank you very much, Jose, for the introduction, and thank you very much to Biotech for inviting me to speak about my experiences with the Optiflex TRIO. Here are my financial disclosures. We perform studies for Biotech. And if you look at the Optiflex TRIO, you can see it's a regular trifocal C-loop hydrophobic, but you can also see that the periphery of the IOL is monofocal. And with only having a center of trifocality that reduces the risk of dysphotopsia under dim light conditions with larger pupils. It's available as a toric version. The material has a high Abbey number, reducing chromatic aberrations, and it has a 3-edge design like most C-loop lenses of hydrophobic acrylate. If you look at the MTF values and the light distribution, you see that it has a quite high peak for intermediate at 1.85 diopters. That means that this trifocal does not focus mainly on distance and near. It focuses mainly on distance and intermediate as well. As the stray light from the intermediate focus point is transferred to double of the add power, there is also a significant amount of light used for near coming from the intermediate. But so here you really have good intermediate vision and good near visual acuity as well. The other thing is it has a small filter in it, very close to the normal natural human lens. So the comfort for patients after surgery, especially in like early cataract patients in the beginning 60s, they don't feel any color changes. You can see here the implantation. I'm a laser surgeon, so I usually implant only with OVD in the cartridge. You can see that the unfolding time of this hydrophobic material is quite fast, and then you just extract the viscoelastic behind the optic, in front of the optic. The lens centers very well, and basically you are done very quickly implanting the Optiflex TRIO. But it's a very handy and easy lens to implant. Could you? Perfect. I think the more important part is actually how is the outcome of the patients. And you see we measure visual acuity in different distances, usually 80 centimeters, 60 centimeters, and 40, and in distance. And you can see that the uncorrected visual acuity in those distances is quite good, especially in the intermediate range. So we had a very high patient satisfaction with those lenses. If you want to have a wider overview of the performance, you look at the defocus curve. And you can see here that you really have a very flat intermediate focus going down to near. So you still have your peak for distance, like most trifocals, but you don't have those typical dips between the intermediate and the near visual acuity in those patients. And the minus 2.75 relates to roughly 45 centimeters where the patients can read newspaper print very well, which for German standards, when people are taller, is the actual size that they use for book reading too. The most discomfort or the most unhappy patients you have because of dysphotopsia. So we do a lot of dysphotopsia evaluation, and you can see here the majority of the patients that we have implanted said they have no problems with glare, it's not disturbing, and the effect is not too strong, and the results are a little bit higher with the halos, which is normal. The lens has a diffractive profile. If the patients would not see the halo, something would be wrong with the lens, especially in the beginning. So we also counsel our patients that they have to see the halos, they have to see those rings, and with that they already know what they expect. So even they see the halos and the halos are strong, they don't bother the patient because they knew that that is going to come, and that's the optical design behind it. If you look at other parameters like how foggy is your vision, how bothersome is foggy vision, how blurred is the vision, you really see that the outcomes of the patients is excellent and they hardly have any problems with it. So in conclusion of the questionnaire, we have a low grade of problems with dysphotopsia. The patients experience that they don't have many problems, only what to tell them, that they are going to have halos, and they have a very stable vision, especially from distance to intermediate. So for me, it's definitely a new option that I can use for presbyopia treatment, offering a wide range of vision. If you tell the patients that the intermediate distance will switch rather from 35 to roughly 45 centimeters, then they're very satisfied, especially if you have taller patients. The patients don't experience many color changes after implantation of this lens, and I do think it's just a very good possibility in the correction. So thank you very much for your kind attention.
Thanks very much, Florian. I think, well, you can respond from there. Yeah, perfect. Much more comfortable. So, no questions? Do you have?
Oh, yes, I do. Dr. Kretz, is there any specific criterion or any situation not to implant Optiflex TRIO to a patient besides well-known pathologies, corneal retinal pathologies? I should assume you have a patient who has only cataract and nothing else, and you are inspecting the patient and everything goes okay for an implantation of a trifocal intraocular lens. So still, might there be any specific reason to give up and just prefer another brand or something like that instead of Optiflex TRIO? I would ask this question to any surgeon who is dealing with one type of brand intraocular lens. So sometimes I would like I do have received some interesting results. So I just wanted to keep asking this question to you. My reasoning is, there is no medical condition to give up from a trifocal intraocular lens implantation to a patient, but still, in sometimes, you prefer this lens or this lens or this lens. So does it make any difference in your decision?
It actually is a very easy question. So we do a lot of dysphotopsia evaluation before the surgery. So we run questionnaires with the patients, we put them in front of the halo glare simulator, we let them adjust their actual glare, and especially in cataract patients, you will see a significant amount of glare. And then if you compare those subjective results to each other and counsel the patient, you can realize and find out which patient will accept the halos they get later. So if I have the feeling that a patient is not going to be in any ways accepting this photopsia, I don't implant any diffractive lens. That's my only reason not to use that. I do implant trifocal lenses in unhealthy eyes. So if a patient has drusen, if a patient is a diabetic but does not have a macular edema, if the patient has a glaucoma and he still has the central 30 degrees of free vision, I don't see any reason why this patient would not benefit of presbyopia correction. And I do counsel them more and more intensively, but I do implant an Optiflex in those cases as well. And so far I have not seen any study or any data that shows me that a patient that develops macular degeneration, macular edema, diabetic edema later on, that he has not benefited from the trifocal or the presbyopia correcting IOL he has received before. And to my knowledge, I also don't know many cases where presbyopia correcting IOL was explanted after the patient developed more pathologies regarding his retina.
Okay, thank you. Do you have also any age interval or preferences in patient selection?
Excuse me.
Do you have any age interval preferences in the patients to implant such an intraocular lens, trifocal, I mean?
I think when they're too old, you need to look rather at the pupil size than at the, and at the age. And for young patients, it's more if we have the possibility to do the presbyopia correction on the cornea, using Presbyon or Presbymax, I prefer to do the presbyopia correction on the cornea rather than doing a clear lens exchange, but that's more for the risk of retinal detachment than for anything else.
All right, thank you.
Florian, a couple of things. I presume that when you say that, and I agree with you, that in those patients where we have implanted a trifocal lens and they, because of the age, develop retinal problems, it's really infrequent, the need to explant because of the disease, the lens. I agree with you. I presume that the retinologists would not think the same if they need to treat a diabetic case with a laser because it's a little bit more difficult. But anyway, I agree with you.
But for that reason, the Optiflex is perfect because the periphery is monofocal.
Yeah,
and usually the diabetic treatment would be in the periphery.
That's what I wanted to ask you about that. It looks like it makes more than sense that having less rings at the periphery allows to have a less chance to have visual disturbances. For example, driving at night or whenever you're looking too far. But with your experience with these lenses and with others, which one between the trifocals that you have been working with, things that penalize more distance vision?
Oh, I think distance vision is always penalized when the pupil size is becoming larger and you have too many rings in the periphery. So it's always distinguishing. For me, it's very important what light circumstances patients work with. If you have patients that like to read a lot and you have a feeling they're a little bit older, so they don't have LED lights in their house, they do perform, in my experience, better with a lens that has rings into the periphery. But if you have the feeling that it's a patient that is driving more at night, that does not have those difficulties, I prefer to use an optic like here where the periphery is monofocal. And there's other lenses that are based on that principle as well. And I do believe that it's just more individualizing for your patients. That's why we have a lot of questions that we really ask the patient and counsel them for, because I do believe the optical quality of those lenses is all good. It's more you have to find which patient needs which light intensity on which focal point and what side effects, because it's only physics that we can play with. But then it works as a very good system.
That one. Last question.
Just a question on Florian. With your experience, could you highlight as the main advantage or feature of this lens if we compare it with another trifocal lenses in the market?
Well, first thing, it's a hydrophobic, a C-loop trifocal, which unfolds very quickly. I like to use hydrophilics because they unfold quickly, they're easy to center in the eye. So that for me is a benefit. The surgery is faster, it centers nicely. The other thing, it sits very rotational stable for a C-loop. and that for me is a true benefit. What I really like about it is my patients are very much intermediate focused, and many of like the first trifocal models, they put their focus on near. Personally, I like this concept that you have more intermediate, because for me, newspaper reading, where the newspaper is lying on the table, is intermediate distance. It's 60 centimeters, it's not 40. And so I do believe that those patients benefit for having more light intensity at the intermediate range. The other thing is you just have less loss of light, because half of your lost light is transferred to the near point where the patient can use it. And I think those are the main highlights about this lens, that they really did a very clever way in using the light intensities.
Thanks very much, Florian. Now I have the pleasure to invite Alexandra Arango, a good friend. She's currently associated as medical director at Institute of Cornea and Ophthalmology, surgeon specialist in cornea in Hospital Germán Trias y Pujol, Barcelona, Spain. And today she will talk about from her point of view, key indications of the Optiflex TRIO toric models.
Thank you for the kind invitation, and thank you to Biotech for inviting me to this interesting symposium. I'm going to try to show you our results with the Optiflex TRIO toric IOL. Here's a brief review in terms of safety and efficacy in a prospective study that was focused on our residual refraction in our first patient. It was actually 34 eyes. All emmetropic patients were excluded. And I would like to talk about the exclusion criteria that we've got right now when choosing a trifocal IOL. So when we're going to take into account pupil diameter, the angle kappa, and special mention to the root mean square at 6 millimeters for high order aberration. So we will exclude patients with more than 0.35 microns. But if we look at the root mean square of 1 diopter of astigmatism at 6 millimeters, we will find that the value is almost double than the one for the high order aberration. So many surgeons with 1 diopter of astigmatism, they will go for an spherical choice. So here are our results of uncorrected distance visual acuity and a small amount of simple myopic astigmatism. So if you look here at with the rule astigmatism, you can see that it has a low influence in far distance vision. We shall consider the natural evolution against the rule astigmatism as years go by. So we might want to target our patients with the rule astigmatism of around 0.25 diopters. If we go to the against the rule astigmatism, this group shows a higher influence in far distance acuity. When implanting monofocal IOLs, we felt comfortable with a residual against the rule astigmatism, since it was going to help with the reading vision. But when talking about trifocal IOLs, this is completely unnecessary, and it's definitely going to affect far distance visual acuity. And if we look at the oblique positions, it certainly affects distance vision. So looking at this slide, we want to go into the blue results, almost emmetropic or slightly with the rule astigmatism up to 0.25 diopters. Here's what we don't want to have. We don't want cylinders of more than 0.75 diopters. We don't want oblique positions, and we have to avoid an spheric equivalent higher than 0.5. So I'd like to take special attention to this group, since many surgeons will go for spherical choices. when having corneal topographies with 0.75 up to 1 diopter of astigmatism. So remember when we were talking about the root mean square? So if we consider treating these patients, we are not only going to avoid a bad far distance visual result, but we are also going to be able to get uncorrected distance visual acuities as good as for the toric group as for the spherical one. And not only visual acuity, but also considering a final refraction. So if you look at our medias and our standard deviations, we were able to get a better precision in the toric group than we did in the spheric group, and this was because we treated really small amounts of astigmatism. When calculating a toric IOL, it's harder to do it, to correct small amounts of astigmatism due to the natural posterior astigmatism, corneal posterior astigmatism, since it's going to have a higher influence for 1 diopter to 3 diopter than to 3 diopters of astigmatism. But with the actual software that we've got, as is the Biotech calculator, it will include the posterior phase, and we will be able to be simulating to get the results we want. So our take-home message would be that treating small amounts of astigmatism will lead us to more satisfied patients and better uncorrected visual acuity. We should always avoid postoperative spheric equivalent higher than 0.5, and we should avoid a postoperative oblique residual astigmatism. Thank you very much.
Thank you, Alejandra. So if I understood well, you are prone to calculate the pre-op astigmatism using both the anterior and posterior.
Right, yeah.
Okay, okay. Very well. I absolutely agree with you. And so don't you think that possibly in the near future, which is your limit in correcting astigmatism with the IOL? Do you select a toric lens from 0.75, from 0.9, from 1?
From 0.75.
Okay, yes?
Yeah, it's really important that every surgeon gets to know their surgical induced astigmatism. Mm-hmm. Actually, I moved to radically treat small amounts of astigmatism since I induced more than I used to in one patient, and it was an oblique astigmatism. So I had a very bad result. And the bad thing is that she had a dense cataract in that eye, but in the other one, she had a clear lens. And since she was hoping to have a trifocal treatment, I had to go on to the other eye.
Okay. I agree also. Any additional comment?
Well, I would like to ask you a question. At first, thank you for the presentation, but I will ask you about your opinion and your algorithm you might have been using for the decision-making with refractive lens exchange. Do you use this lens? Are you fond of using this intraocular lens in cases of clear lenses, the patients without any cataracts?
Actually, I'm not really fond of clear lens exchange, but I've been practicing for patients with some degree of ametropia above 50, like 55, more than 50. But I have some patients with 52, 53, plus 2, plus 3 diopters of hyperopia. So yes, I do practice clear lens exchange.
Thank you.
Okay, Arantxa. Yes, Ramon.
Excuse me, Alessandra, congrats for your speech, but I have missed some information about the rotational stability of this type of lenses. How was your experience?
It was excellent. Actually, we didn't have any problem with rotation. It's very stable, and we didn't have to rotate any IOL.
Alexandra, thanks very much.
Thank you.
I would also like to thank not only her, but also all the speakers for sharing their experiences with all of us. Also you to stay here, and especially Biotech Healthcare for organizing this session. And we hope that I know that we have learned something. So thanks very much to all of you.